Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
So the next question that we're going to cover is, can immunotherapy help patients with small cell lung cancer rather than non-small cell lung cancer? And the answer quickly is, of course, immunotherapy can help some patients with small cell lung cancer, just as it can help some patients with non-small cell lung cancer. And we'll go through some of the reasoning of how this might be. So first of all, the question is, what are the predictors of response to small cell lung cancer, and how might those differ from non-small cell lung cancer? In non-small cell lung cancer, as I discussed in another module, some of the predictors of response are PD-L1 status. Doesn't seem to be as predictive in small cell lung cancer in multiple clinical studies that have been reported. Tumor mutational burden. The more mutations inside a tumor, the more likely it is to cause antigens, things that stimulate the immune system overall. And when the immune system is trying to fight the cancer, then it may develop that PD-L1 shield. Small cell lung cancer, even though it's highly mutated and probably has multiple antigens, doesn't seem to have TMB as strong a predictor of response as non-small cell lung cancer overall. So I think we still have a lot of work to do in identifying what are the predictors of response in small cell lung cancer, but we do know that immunotherapy can benefit some patients with small cell lung cancer overall. So we can use tumor testing and predictors of response overall to decide who should receive therapy, but I would argue that every patient with small cell lung cancer probably at some point and some line of therapy probably will receive immunotherapy. Unless there's some strong contraindication, for example, pre-existing autoimmunity, and an exacerbation of that may be life-threatening overall, or prior solid organ transplantation, for example. But most patients can receive immunotherapy relatively safely, and the side effects can be managed. So what about the evidence for use of immunotherapy in the first-line setting of small cell lung cancer? So historically, we try new therapies in the later line setting. So, first in patients that have been heavily pretreated, then maybe move it in the second line setting, then eventually move it in the first line setting. Over the last year and a half, there have been some exciting data showing that immunotherapy indeed can have effects in small cell lung cancer. So 2 different trials recently were conducted, very similar structures overall, both with platinum, carboplatin, cisplatin, etoposide. This is the base chemotherapy regimen that we offer to patients with newly diagnosed small cell lung cancer, and added or did not add immunotherapy. 2 drugs were tested, PD-L1 drugs, both of them actually. One was durvalumab, and the other one was atezolizumab. So the atezolizumab data came out first, and this demonstrated a strong and significant overall survival benefit with that regimen, platinum, etoposide, plus atezolizumab overall. And this regimen has now gotten FDA approval for the treatment of small cell lung cancer. When we look at the differences between patients who got atezolizumab and those patients who did not, there is a survival benefit, but it looks like maybe roughly 10 to 20% of patients are the ones who are benefiting, and 80% of patients may not benefit from that addition of immunotherapy, although chemotherapy for sure has high response rates in small cell lung cancer. So it's only as we follow patients over multiple periods of time, a year or 2, that we start to see these differences emerge, because chemotherapy by itself is so good right away for shrinking small cell lung cancer. There's also a clinical trial with durvalumab in addition to platinum and etoposide, very similarly designed study. And we just saw data of this trial released this summer at the World Conference in Lung Cancer in Barcelona. And in this trial, the Caspian trial, The addition of durvalumab to platinum etoposide also resulted in increased progression-free survival, time until the tumor grows back after first-line treatment, as well as increased overall survival. In fact, the magnitude of benefit between these two studies looked very, very similar, suggesting that the drugs are acting in almost an identical way for this very similar patient population. So both durvalumab and atezolizumab have so far been proven to increase and improve benefit for patients with small cell lung cancer in the frontline setting. And I would argue that that's currently the standard of care for patients, and hopefully most doctors are offering this therapy with the platinum and etoposide. So what about second and third line setting? If we give immunotherapy in the frontline setting, currently FDA approved is atezolizumab, although I wouldn't be surprised if durvalumab and other agents were to follow. Should we give immunotherapy in the second and third line setting? Well, for patients who haven't gotten immunotherapy before, there are certainly strong data for immunotherapy in the second line setting, drugs like nivolumab or pembrolizumab. Nivolumab is technically approved in that second line setting for small cell lung cancer, whereas pembrolizumab has approval now in the third line setting for small cell lung cancer overall. These would be in place of other drugs that had historically been in the second line setting, for example, topotecan, or oftentimes we use irinotecan. And before we were using immunotherapy in the first line setting, I would often discuss with patients after their tumor had grown, after prior therapy, I'd say, well, should we try immunotherapy? And there's a chance that the tumor will respond. Again, it's a low chance overall, but chemotherapy doesn't have a super high chance of response. And so the question is, should we try chemotherapy? Almost the safer bet, some chance of disease control and stabilization, maybe a little bit higher, or immune therapy that has a lower chance of a great response overall, but maybe doing nothing for this rapidly growing cancer if the immune system can't be harnessed to try and target it. So there used to be a question, should we use immunotherapy in the second line setting, or should we use chemotherapy there, or should we put immunotherapy in the third line setting? Without strong predictors, it was hard to decide on an individual patient basis, so it was more of a in-person discussion. But now since we've moved immunotherapy to the frontline setting, I think it's not really a discussion point anymore. I haven't had patients for whom, either with small cell lung cancer, non-small cell lung cancer, for whom treatment with an immunotherapy worked really well and then stopped working, and then we tried another immunotherapy and then it worked really well and worked in a different way. So all these different drugs, I think, work in a very similar mechanism. If one immunotherapy doesn't work, another one's probably not going to work. There is one maybe exception, and I think more data need to be generated, though, with ipilimumab. So most of the immunotherapies that are FDA approved in small cell lung cancer and non-small cell lung cancer work against the PD-1 or the PD-L1 axis. That's that shield that I talked about earlier that's protecting the tumor from the immune system so the immune system can't come in, and these drugs block the shield. There is another drug called ipilimumab and a cousin of it, tremelimumab, in the same category. These are called CTLA-4 inhibitors. So CTLA-4 is another off switch for the immune system overall, but inhibiting CTLA-4 causes a much more activated immune response. So this is kind of making the immune system stronger overall, making it more activated. And if you combine those types of drugs together with the anti-PD-1, PD-L1 blocking the shield, maybe you'll get a better, stronger response against the tumors. So in small cell lung cancer, the combination of nivolumab and ipilimumab have been tested in a clinical trial where patients got and investigators gave patients the choice, nivolumab or nivolumab, ipilimumab. It wasn't randomized, but in this clinical trial, patients that received nivolumab and ipilimumab perhaps had slightly stronger responses overall, slightly higher chances of responses. But this comes at a price. So as we turn up the strength of the immune system response with ipilimumab, the chance of autoimmune side effects gets much higher. So some of the autoimmune side effects we worry about in lung cancer are pneumonitis, drug pneumonias, hepatitis, inflammation of the liver, or colitis. And in particular, colitis can be much more frequent with the addition of ipilimumab than with the checkpoint inhibitors, the PD-1, PD-L1 inhibitors alone. So for me, my personal practice, there are selected patients that I've offered nivolumab and ipilimumab to. I don't think I would do that after first-line chemotherapy and immunotherapy, but in the second or third-line setting for a patient who hasn't previously received immunotherapy, we could certainly have a discussion about nivolumab plus ipilimumab or other CTLA-4 inhibitors in that setting.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate and visit us for more information at cancergrace.org. Thank you for listening.